Hello everyone. In my series on antimicrobial resistant organism and antibiotic selection, in today's video I am going to discuss about antibiotic selection for the resistant Pseudomonas aeruginosa infection. I am Dr. Sunil Garg from Essentials of Acute Care. In the last part of this video, you will be given few questions related to this topic. In terms of definition of resistant Pseudomonas, from the treatment perspective, it is divided into two. One is multi-drug resistant organism or MDR organism and another is DTR or difficult to treat resistance organism. MDR is defined as non-susceptibility to at least one antibiotic in at least three antibiotic classes out of five, and it includes penicillin, cephalosporin, carbapenem, aminoglycosides and quinolones, while DTR is defined as non-susceptibility to all antibiotics, all agents in all classes except aminoglycosides. Pseudomonas exhibits various mechanisms of resistance, and it includes decreased expression of outer membrane proteins where drug cannot enter into the bacteria, increased production of hydrolyzing enzyme like Pseudomonas derived cephalosporinase, which is also commonly referred as Pseudomonas MPC enzyme. There can be upregulation of efflux pump where drug can enter into the bacteria, but because of the upregulation of the efflux pump, it is rapidly washed out. There can be problem with the binding in terms of mutation in penicillin binding proteins. There can be a presence of expanded spectrum beta-lactamase like OXA10 and also carbapenemase production. Before discussing treatment of DTR Pseudomonas aeruginosa, here I will discuss the treatment of MDR Pseudomonas aeruginosa. When Pseudomonas aeruginosa is susceptible to both traditional non-carbapenem beta-lactam agent and carbapenem, traditional non-carbapenem beta-lactam is preferred over carbapenem therapy just to preserve the activity of carbapenem. But when isolate is not susceptible to any carbapenem agent but susceptible to traditional beta-lactam agent, the administration of traditional beta-lactam agent is done based on the culture and sensitivity report, but it should be done as a high dose extended infusion therapy and repeat antibiotic sensitivity test is encouraged. But if you encounter the same situation where organism is not susceptible to any carbapenem agent but susceptible to traditional beta-lactam agent, but patient is either critically ill or patient has poor source control, then in such patient traditional beta-lactam agent are not preferred, rather the use of a novel beta-lactam agent that test susceptible is a reasonable treatment option, and these agents includes ceftolozane, tazobactam, ceftazidime, avibactam and imipenem/statin relebactam. Here it is important to note that there is no mention of meropenem vaporbactam. For UTI and pyelonephritis due to DTR Pseudomonas aeruginosa, the preferred treatment include ceftolozane, tazobactam, ceftazidime, avibactam, imipenem/statin relebactam and sapidurocol. There is insufficient data to favor one of these agents over the others, and for the uncomplicated cystitis, single dose of tobramycin or amikacin can be given as an alternative treatment, and for complicated UTI and pyelonephritis, the full duration course of aminoglycoside can be given as an alternative treatment. For the non-urinary infection due to DTR Pseudomonas aeruginosa, the preferred therapy include ceftolozane, tazobactam, ceftazidime, avibactam, and imipenem/statin relebactam. Here, cefiderocol is considered as an alternative therapy. It is important to note that ceftolozane has independent activity against DTR Pseudomonas aeruginosa, and it does not need to rely on tazobactam component. Avibactam and relebactam expand activity of beta-lactam agents mainly through inhibition of the Pseudomonas derived cephalosporinase. and Weber-Bactam only marginally expands the activity of meropenem against DTR Pseudomonas aeruginosa, and this is the reason that meropenem Weber-Bactam is not included against or in the therapy for the DTR Pseudomonas aeruginosa. DTR Pseudomonas aeruginosa isolate, which produces metallo-beta-lactamase, do not respond to novel beta-lactam agents like ceftolozone tazobactam, ceftazidime avibactam, and imipenem celestatin relibactam. In such patients, the preferred therapy is the use of cefiderocol. It is recommended to always repeat antibiotic sensitivity against novel beta-lactam agent if a patient previously infected with DTR Pseudomonas presents with a sepsis-like picture suggestive of a new infection or relapse. In terms of use of combination therapy for the DTR Pseudomonas aeruginosa, it is not suggested if there is sensitivity to novel beta-lactam agents. But the use of combination therapy can be done empirically, like the addition of tobramycin to a novel beta-lactam agent, just to broaden the likelihood of at least one active agent for the patient at risk for the DTR Pseudomonas aeruginosa. But data do not indicate that it should be continued if the sensitivity to beta-lactam turned out to be positive. This is question number 1. Based on the definition of DTR Pseudomonas aeruginosa, which of the following antibiotic is not included in the definition? Here I pause. Please read the choices for yourself. This is question number 2. Which of the following is not a treatment option for DTR Pseudomonas aeruginosa? Here I pause. Please read the choices for yourself. Here comes the question 3. Which of the following antibiotic is effective against DTR Pseudomonas aeruginosa? Here I pause. Please read the choices for yourself. This is question number 4. Please pause it and read the question for yourself. Choices which belong to question number 4 are these. Please read the choices. Please pause the video to read the choices. Here I finish. Please write down your answers in the comment section box where I will discuss with you. Once again, thanks for watching this video, and please do not forget to subscribe to this channel.